Hello, I'm John Bielenson. Welcome to Age-Friendly Beyond the Hospital, Innovation in Hospital at Home, a webinar sponsored by the Hospital at Home Users Group, presented in partnership with the American Academy of Home Care Medicine. We'd like to recognize the generous support of the John A. Hartford Foundation for the Users Group and this webinar series. The Hospital at Home Users Group is the nation's premier collaborative focused on acute care at home. The Users Group shares resources and best practices, works together to expand our program's reach, and informs regulatory, reimbursement, and payment policies necessary to build the field and spread this hopeful, equitable, and person-centered model of care. Please visit our website. You can see the URL there. Be sure to check out our TA Center for the helpful hospital at home program resources and tools, as well as our recently refreshed Research Center. Follow us on Twitter/X as well. Finally, a team of researchers at Mount Sinai is looking to interview hospital at home caregivers for their input on the caregiver experience and a range of equity issues related to hospital at home policy, practice, and research. So we need your help to connect with caregivers. So please, if you want to get involved, simply scan the QR code on the slide or contact us at info@hahusersgroup.org. It's now my pleasure to introduce our moderator for today's webinar, Dr. Bruce Leff, a member of the Hospital at Home Users Group leadership team. He is a professor of medicine at the Johns Hopkins University School of Medicine, where he directs the Center for Transformative Geriatric Research. He has indeed been pioneering research on hospital at home programs for almost 30 years. And these days, you'll see or hear Dr. Leff on podia of hospital at home meetings around the country. He's quoted widely and often in major national and trade media, and he is indeed an important voice in national healthcare practice and policy circles. We're very pleased to have him with us today. Please take it away, Dr. Leff.
Thanks, John, and it's great to be here at our 24th webinar. So today's webinar is on age-friendly beyond the hospital, innovation in hospital at home, and we have a fantastic set of presenters today. Let me introduce today's speakers. We have Dr. Shivani Jindal. She's a geriatric medicine physician and associate professor at the University of Cincinnati College of Medicine, clinical consultant to the VA Central Office, focusing on home and community-based programs. She's worked across multiple care settings in the VA, including hospital at home, and is focused on age-friendly health systems work and is a national leader in that space. Dr. Michael Nassif is medical director of the St. Luke's Hospital in Your Home program. He's a board-certified cardiologist and staff at St. Luke's Mid-America Health Institute in Kansas City. His research interests focus on the intersection between diabetes and cardiovascular disease, with a specific focus on heart failure. We have Michael Lee, who's the medical director for the Kent Hospital at Home program in Warwick, Rhode Island. His area of interest is in the economics of acute care delivery. Dr. Aaron Nepal is a geriatrician in the acute care for elderly unit at Kent Hospital and also works in the Kent Hospital at Home program. And his areas of interest include delirium prevention and management and appropriate prescribing in geriatric populations. And finally, we have Michelle Grinman, who's a general internal medicine specialist and health services researcher with expertise in hospital at home and virtual care. She's the Deputy Chief for General Internal Medicine at the University of Calgary and has led the development of 2 hospital at home programs in Alberta, Canada, and is the lead for the Canadian Hospital at Home Working Group. We have our panelist disclosures today, and I'll just leave that up for a few seconds for you all to view. So it's my pleasure to turn it over to Dr. Jindal.
Hi, thank you. Thank you for having me here today. I'm presenting age-friendly for EMS in the hospital at home on behalf of some work that I've done, as well as my colleague, Dr. Stephanie Pagliuca. So I wanted to start off with traditional inpatient care, what risks it has for older adults. And I know that this group, very much understands why models like hospital at home have high utility, especially for this group of patients that we serve. So older adults are at unique risks when they're hospitalized. That includes function decline, so that's shown there by our walker, risk for pressure ulcers or skin breakdown, of course, risk for delirium, risk for iatrogenic infections, falls, and then also the transitions of care. And I think that all of these together make models like Hospital at Home have very high utility for this group of patients. So I think that where Age Friendly is a wonderful framework that can help us further the evidence-based delivery or delivery of evidence-based tools along many care settings. So Age Friendly is a multi-organizational initiative that includes the Institute for Healthcare Improvement, the John A. Hartford Foundation, and it basically has taken the geriatric 5 M's, which the fifth M is multi-complexity, but made it more compact and into a framework that essentially allows anyone to deliver this evidence-based tools to along clinical settings. And so basically what we have here is in all of the 4 M's, and each of them have an assess and act on piece that go along with each M. And what happens is that the act on portions are the interventions that are indicated that allow for meaningful care to be delivered to the individual. So this infographic is very intentional in the order that the M's are presented. So we start with what matters at the top, because aligning all of the types of care that we provide with what matters, or making it goal aligned for the person that is receiving the care or the veteran, is very important. And the 4 M's is meant to be practiced in a set. So just practicing, 1 or 2 is wonderful, but that allows for growth or an opportunity to get high reliability in the other M's that are here in the framework. So for what matters, it could be simple as just asking what matters to the older adult, but we also have more comprehensive frameworks such as patient priorities care that falls under here. And that has, goal setting and bringing focus to that care and allowing that goal to be known across the different care teams. Medications focuses on a meaningful medication review for high-risk medications with deprescribing and appropriate prescribing in mind, very tailored for older adults. And also considering that symptoms in an older adult may be due to a potential side effect until proven otherwise. And then asking how patients are taking medications. So for example, do they use a pill organizer? Do they need help with healthcare tasks? Do they have missed doses? Mentation varies by clinical setting. So for inpatient care, we focus on delirium. And for outpatient and nursing home care, we also include depression and dementia screening as part of the assessment pieces. And each of those have appropriate act-on tools or interventions to be done for those 3 disease processes. And lastly, we have mobility. So what I've learned about being a part of this movement is that mobility is not just focused on falls. I'm a hospitalist by training or by what I do on a daily basis. And what I really like about the framework is that it doesn't just focus on fall rates. I hear about fall rates all the time on our units and what we need to do to improve that, but it also focuses on function. And so this has, led me to, when I teach my residents, think about that we have to figure out how can that patient that we're providing care for maintain function. So what interventions do we have here in the hospital, such as like an ambulation program, which we have that keeps people out of bed multiple times a day. So things like that has been helpful to think about. So the functional mobility screening can include things like the AMPAC 6 clicks, the Johns Hopkins highest level of mobility. And what I learned here is that a falls questionnaire is not good enough. And what they mean by that is that we really want a functional screen. And what I like about this is that Hospital and Home is one of my favorite models of care, aligns really well with the 4 M's framework. And it's just the fact that we're already doing what aligns with what matters to people. So I recall a veteran I was caring for, I get a call from the emergency department saying this person wants to leave AMA and can we take him in our Hospital and Home program? And it was not leaving AMA. It was just basically trying to provide care that aligns with what matters to that veteran. And so what I really like is that this framework fits so well with the model of care that we all work in here. And then just as an aside is that the Institute for Healthcare Improvement does recognize healthcare systems as a level 1 or a level 2 recognition for their delivery of age-friendly care. And what I found interesting, trying to bring both of the things that I enjoy in my work together is that currently there isn't a specific pathway for a hospital at home or acute care in the home programs. And so we're working on how the 4Ms can be adapted for this model of care and the different frequencies on those worksheets. So what we did is we surveyed the VA hospital at home programs to understand what their views were on 4Ms in this clinical care setting, how they currently practice age-friendly health systems in their programs, and we will be expanding this work with a national survey of VA and non-VA programs. So we'll be going over preliminary results here shortly, but we would really appreciate your participation when that email comes through, and we're very excited to share our preliminary results today. So first, what we have here is that the VA hospital at home program is very typical and similar to our hospital at home model in general. We have a little bit more degrees of freedom for referral sources because we do not operate under a CMS waiver, and VA has had hospital and home for quite some time and has tailored it to our veteran populations and rurality as well. So we had 9 out of 11 programs respond, and what we focused on was our hospital at home medical directors and what they thought for their program, and also got some demographic data for the veterans that they serve. And so what we, just for main disease processes that we serve is heart failure, COPD, cellulitis, UTI, pneumonia. And as I said, we do vary in our referral source. We do take folks from home as well, even our telehealth programs that will see if someone is starting to trend up in weight, we will intervene. And then we also even get referrals sometimes from our home-based primary care colleagues. And so first we'll start with what matters. So we have here in our chart here the perception of importance from our medical directors, the general practice, and tools in use. So we're really curious about all 3 of these buckets because we wanted to know if our tools in use align with what, say, the IHI accepts for recognition, because this is our whole hope, is to have a pathway for recognition for our programs. So first you see here on what matters. So 78% of the programs that we survey believe that it's very important or extremely important to align the care with what matters, and 78% routinely assess. And what we found interesting here was we also asked about caregivers. So please participate in the caregiver survey that John had mentioned earlier, is that 56% routinely screen for caregiver stress or burnout. And when taking care of even just more complex group of patients, regardless of age, caregiver stress is something that we should be screening for and working to provide resources. So, and what they do is they ask about goals of care paperwork and also what their goal is for a hospitalization. So next, for medications, 89% believe it's very or extremely important to screen for high risk or potentially inappropriate medications. 89% routinely do this, and they do it with a medication reconciliation with the bottles at home, so which is the plus point of being in the home, and also pharmacist reviews for those teams who have pharmacists on their teams. And then Mentation was a place for where we got multiple different types of viewpoints. So 67% believed it was very or extremely important to screen regularly for delirium. 11% routinely screen for delirium, and 44% routinely screen for depression. So they would use clinical judgment for the delirium screen. And I think this is where we have some openness to discuss what appropriate parts of Mentation are, or what parts of Mentation are appropriate for hospital and home. And lastly is mobility. So 100% of our programs believe it's very or extremely important. 100% of the programs screen, and then they do this by observation of ambulation or self-report from the patient or the caregiver. So this is what we would love to share, what we wanted to share today, and I'm looking forward to hear what our colleagues who are going to be presenting, what other work they've been doing in this space.
Thanks, Dr. Jindal. Great setting the table. So Shivani was sort of giving an overview of the M's, and now the ensuing presentations are going to focus on all of the M's in separate presentations. So Dr. Nassif, take it away and tell us about Mentation and meds.
Thank you so much. And like you said, I'm Michael Nassif. And you can go into the next slide. And the one disclosure you didn't mention is I'm the only non-geriatrician on here, but this is a lot of the work of Jill Hudet, who's our full-time geriatrician in our hospital in your home. And she had a family emergency, but this worked well because Jill's very humble, so I can brag about her and some of the incredible things that she's been doing. And one of my overall messages would be, we're 20 months old, and we just admitted our 1,000th patient, but we did 14 of those months with really no geriatrics presence. Then the last 6 months, we've had Jill as our full-time geriatrician, and the quality and caliber of care is completely different. So one huge take-home message would be whether it's geriatric consultants, geriatric inclined or trained nurse practitioner, I think it really is essential in the hospital in your home setting. We had started with all Medicare. Now we have some private payers, but we still have our average age patients nearly 80, and 77% of our patients are over 70. And so the first thing Jill has instilled with us, and it really starts the second they get in the door, paramedics are doing these functional status and IADLs and fall risk questionnaires. And then Jill consults on the great majority of our patients. And we'll show you some of the statistics. But the screening tools we're currently using for cognition is the 88, the SLOOM's the other big one, and then BCAM. And Jill we'll show you some of the data. The 88 seems to be very sensitive, but not maybe very specific in terms of dementia screening. So we're open to other suggestions, but we're also screening for depression, polypharmacy, functional status, fall risk. And then we're starting to do more and more of caregiver burden, which I think is particularly interesting in the hospital in your home setting, as well as in a more of a longitudinal setting. And so 88, as I mentioned, I'll show you, we have about 57% of our patients thus far have had 2 or more positive in the 88. Less have had positive screenings with mini cogs in the SLOOMs. And one of the things Jill does that I don't know in a busy brick and mortar setting that people really have time to do, and you can go ahead and click forward, is Jill, I joke, is like a detective on Law and Order, and she is getting alibi witnesses, corroboration witnesses, and talking to family members, and really doing a 360-degree view of the patient's overall mentation and home situation, which, in the brick and mortar setting, when we're all running around their heads cut off, I don't think is nearly as possible. One thing I think the hospital in your home setting really lends itself to do. And we do have virtual clocks to assess executive function. And one of these was my longtime patient, which I would have I was greatly overestimating his executive function. But the patient's actually, it lends itself very well, and it's very easy to take a picture and very easy to share screens likewise with the patients in the hospital in your home. And so as far as, mentation for the first M, the other one we do is, in addition to talking to family members, communicate with PCPs. One of the big things is we're starting to compare to the brick and mortar hospital, but I think being in the hospital in your home itself is big delirium prevention. And then Jill in the geriatrics consultation is big on deprescribing, and we're actually starting to get some data back on number of meds patients start with and number of meds they end with. And I think comparing to the brick and mortar, especially in terms of new sedating or altering medicines started the brick and mortar compared to the hospital in your home. We do have a psychiatric consult service, which we've used on a handful of occasions. And we do have more in-depth outpatient neurocognitive testing, but the hospital in your home is a great place to start. And so we're doing that BCAM. Our nurses do this. The nice thing about it, it's very fast. The nurses are very familiar with it. It takes them less than a minute. And we'll show you our data here in a second. And the positive screens, lead us to what is a preventable, reversible etiology of delirium versus more long-term impairments. And the one big one we mentioned, deprescribing. I think most hospital in your homes have realized really quickly that it's a heavy lift on pharmacy. So we do have 1.6 FTEs of pharmacy just dedicated to our hospital in your home. And one of the big opportunities I'm sure many have realized is seeing what the patients actually are taking at home compared to what we think they are taking at home, being able to reconcile these. And then also we'll show some data on deprescribing and the amount of polypharmacy in this Medicare hospital in your home population. And Jill's very liberal about DC, I would say all meds, but also over-the-counter meds with a huge focus on benzodiazepines, opiates, and sleep aids. Likewise, we do a lot of communication with the PCPs and even long term. We're hoping to start doing more transition of care. We're currently doing acute care only, so it's that 4-day hospitalization. But as Jill will tell you, there's actually a lot of communication even after patients have been out of the hospital in your home for months from both patients and PCPs asking various questions and medication questions. Currently, we are using lock boxes, electronic lock boxes for our controlled substances. And we're starting to do barcode scanning to help, as I think Bruce and many others have showed, all the hospital in your home outcomes are far superior except for medication errors, which we've also had. And we're looking at ways to improve that over time, especially with the geriatric population. Perfect. And here's some of our results. As I just mentioned, Jill just joined us last August in September. And so thus far, the patients receiving geriatric consults have been age 82. 57% have had some cognitive impairment based on the 88, less so based on the SLUMS and the mini cog. But the functional status having some detriment in their ADLs or IADLs is significant. In 30% of our patients have had a fall in the last 3 months prior to hospital in your home. And I think that gives some background to, we have a 3 or 4% fall rate in the hospital in your home, which some say is higher than it is higher than the brick and mortar hospital, but the counter argument is they're far more ambulatory in hospital in your home than they are in the brick and mortar hospital. And polypharmacy, depending on the definition, but 83% of our patients getting geriatric consults are on over 10 meds at home. And it does decrease after the geriatric consultation. And then likewise, caregiver burden. We're starting to measure this more frequently. In caregiver strain is about half of our patients getting geriatric consults. And major caregivers most often the child, and less so the spouse. And as far as the kind of outcomes of our geriatric consultation, so the 5 M's are addressed, 83% of the time. There's communication with the PCP almost 95% of the time. The code status has changed 23% of the time. What's remarkable about that one is these patients, were already hospitalized in a brick and mortar hospital, already had their code status addressed with a physician. But I think after being at home, being more comfortable and spending more time with a geriatrician, a quarter of them changed their code status. The TROPE, which is the transportable physician orders for patient preference and outpatient code status, is completed in 30% of the patients. Advanced directives are initiated in 15% of the patients. And as I mentioned earlier, as far as deprescribing, 61% leave on less medicines than they came into the hospital in your home, and about 10% are receiving a hospice referral. And so where do we go from here? So Jill's incredible, but she's one human. So we do need to expand our team, and geriatricians are rarer than hen's teeth these days. So we do have some initiatives to do some training with our advanced practitioners, nurse practitioners, as far as having a geriatric focus. We're also looking for more opportunities to do like a day 7 and day 30 transitional care visits with the patient. So we have a little bit more of a longitudinal presence than just the acute hospitalization. Then we're looking for long-term, everyone's kind of laser focused on 30-day readmissions, but I really think that's a low bar. We want to see longer term what we can do with future ED utilization and future hospitalizations. Then we'd ideally like to eventually have some impact and start some of these in the brick and mortar hospital before many of our patients end up in the hospital in your home. Yes, and just thank you. We've been started with Medically Home for the last 2 years, been a valuable partner. And Linda Sherry was very valuable in many things, including recruiting Jill Hudad to join our Hospital in Your Home team. And I'd also like to thank the Hospital in Your Home users group for having me today. I'll turn it back over to Bruce.
Michael, thanks so much. Thanks for giving us the update on mentation and meds and for touching on what matters as well. Also a little bit on mobility. And that's a great segue into a discussion on the mobility M. And we have Michael Lee and Aaron Nepal. Take it away.
Bruce, thank you. It's a pleasure to be here. We're here to talk about mobility. A brief intro about our program. We are part of the Care New England Health System here in Rhode Island. We're a community hospital, about 300 beds. We're also a teaching affiliate of Brown University. We started in 2022. I would describe us as still in a growth phase. We recently hit approximately 5% of our hospital's volume, which was a big milestone for us. One thing I'll say about our program, as with many programs, we have our roots in geriatrics, founded by a geriatrician. And we've actually formalized that. So there's sort of an integrated service line that combines geriatrics, the Department of Geriatrics and Hospital at Home, along with palliative care. So there's sort of a unified administrative structure, medical leadership. And the benefit of that is that we sort of have shared culture, approach to patients, shared staffing, and in building a consult service, it's been easy to build those between palliative care and geriatrics, for example.
So we're very fortunate that at Kent Hospital, they've been on the pursuit and had a strong commitment to age-friendly care for a long time now, going back as far as 2014. And that kind of started with the beginnings of our geriatric consult service. And that's grown quite a bit since then to include our acute care for elders hospital unit that uses the 4Ms framework for all of the patients that are admitted to the unit. We have ambulatory geriatrics consults, a dedicated older adults primary care office, and now we have our hospital at home program. We've also achieved committed to excellence status for our Kent Hospital inpatient and older adult outpatient practice settings for age-friendly care. So we're always in pursuit of adding age-friendly care wherever we can in our patient care avenues. And we're currently in the middle of pursuing a geriatric surgery verification commitment level status for our hospital as well. So that's an ongoing project for us. Hospital at home and caring for patients in their homes lends itself really nicely to mobility as well as the rest of the M's, just kind of by the nature of how we're caring for these patients, and it gives us the opportunity to encourage, optimize, and preserve their mobility and function by the way that we're caring for them. So some of the aspects and examples of how that applies to us and our patients is first and foremost, keeping them in their familiar home environment lends itself to reducing their risk of delirium, and that comfort and familiarity with their home environment allows them to be more willing and able to ambulate and remain mobile. It also gives us that unique opportunity to be in the home and recognize any safety concerns as it relates to their mobility that we might not know otherwise if they're treated inpatient in the brick and mortar, so to speak. We're allowed the opportunity, and by the kind of creative steps that we take to make hospital at home work, we're able to achieve less tethering and mobility restrictions for our patients that are associated with our treatment and care plans. And by that, I'm referring to examples such as IV lines, Foley catheters, other technology or lines that have to be attached to the patient. We're able to do it in such a way that prevents them from being restricted to the couch or to the bed, and really allows them to have kind of free run of their home the way they would normally. One of the big challenges we have on an inpatient basis for older adults is their toileting routines and practices, dealing with incontinence and mobility affecting their ability to use our different avenues for toileting. So being in the home and in their most familiar setting, we can really encourage them to maintain those toileting and hygiene practices that they follow regularly, and identify opportunities to improve on those in ways they might not have appreciated. We find that our patients on the hospital at home service tend to have really great support systems, and we're able to engage and utilize their their support and their knowledge of the patient to our benefit and to their benefit. So we really like to get them engaged and participating with us in caring for those patients as best as we can. And we can utilize some of the technology we have, like bracelets and some monitors that we attach to patients to quickly detect falls, kind of get a sense of their mobility by watching their step counts. And it also allows us the opportunity to quickly respond to clinical changes that might be happening when we're not physically present with the patient.
All right, so what are some other specific things that we do at Kent Hospital at Home for to ensure safe mobility? I think the biggest thing we've done is to partner with the PT OT department very closely, and this has been tremendously beneficial. So our hospital has like a morning blitz rounds where we go through the entire hospital census, and the various hospital teams will discuss their plans for their disposition and so forth. And we sit right next to the physical therapists, and as we go through all the patients in the hospital and we identify patients that might be hospital at home candidates, if there is a potential barrier with mobility or debilitation, like physical therapy will commit to prioritizing their assessments, and so it's a wonderful partnership because we can get them to do the assessments, to do them quickly, and not only that, but there's been a fair amount of education with the therapist about what exactly we're looking for. They understand our criteria, and they understand what our capabilities are and what our limitations are. And as that relationship has grown, they've been an incredible resource in helping find patients that are at highest risk of debilitation by staying in the hospital and being kind of stuck in their bed, versus doing a projection of what that might look like if they were to get home early and mobilize from day 1 or 2, to be able to avoid the various complications that we know come from staying in the hospital. The other thing that's been important for us is that our physical therapists will continue to work with our patients while they're admitted in their homes. And that's with not just home assessments, but also beginning the therapeutic work in the home. And it's not quite the same therapy that they would be getting post-discharge with your VNA services. They're coming every day as opposed to 2 to 3 times a week that might be expected post-discharge. The intensity of that work is going to be very specific to the medical issue at hand, and recognizing the specific limitations of somebody that is, there for a COPD exacerbation and has oxygen and, might be dyspneic on exertion. So it's very, very specific to the case at hand. As Aaron mentioned, we make use of the technology, the fall detection, the monitoring of step counts and so forth. The platform that we use, we're very happy with that, and it's been a great tool to have. And finally, having a great relationship with the durable medical equipment part of our hospital, to be able to supply whatever tools are needed in the home to allow a patient to succeed, whether that is a hospital bed or a recliner or commode. And if the DME department is not able to provide that, our care managers will work very hard to find that equipment either in the community or elsewhere. And that's all we have. Thank you.
Thank you.
Gentlemen, thanks a lot. My pleasure now to pass the baton to Michelle Grinman.
I'm an internal medicine doc in Calgary and started a program called the Complex Care Hub, which was aimed at, in 2018, which was aimed at helping mostly medically complex and frail older adults in Calgary, Canada. And so I've been asked to talk about what matters most for patients in hospital at home and talk a little bit about the lessons learned from our program in Canada, in Calgary, Canada. So I'll talk a little bit about how we kind of, as Bruce says, baked in or incorporated what matters most into our hospital at home program. Talk a little bit about patient, caregiver, and provider experience related to what matters most in hospital at home, and then talk about lessons learned. The way that we envisioned, like we did an environmental sort of scan of what was happening in Calgary at the time to decide on our population. And we decided that given all of the services and resources that we had in our city, that one of the populations that was kind of falling through the cracks was the, what I call pre-palliative population, or kind of the older adult that is in the last few years of their life that needs kind of like a progressive palliative approach to their care, but they're still not considered to be palliative in terms of the way the healthcare system looks at them. And so that was the population that we initially targeted. There's 5 components that we add, sort of incorporate into our hospital at home. So because of the population that we selected, actually, can you go back? Because of the population that we selected, we do a lot of complex care planning. Our nurse navigators are actually what we call transition services nurses, and so they can connect with home care and with all the community services that frail and vulnerable adults need. We also do a lot of medication management, as most hospital at homes do, but a lot of teaching around medication management and supporting with access to restricted medications that we have here, because the government pays for a lot of the medications here. So helping with funding and all of those things. We do a lot of meeting the patient where they're at, teaching them about their chronic conditions, and at the same time coming up with action plans for them not to have to come back to the hospital when they leave. And also linking our patients who have these chronic conditions with the right providers. So if they don't have a family doc, we connect them with a family doc, which is a huge problem in Canada right now. And also if they need specialists or anything in particular that they don't have access to help them manage in the community. So our hospital at home is kind of a hybrid of in-person and virtual care. We have a hospital-based team, and then we have a home-based team. So in the hospital, we have a physician that's either a general internal medicine doc or a family medicine hospitalist, and they're the ones that direct the care plan, conduct the virtual visits, and expedite workups, which in Canada, sometimes people get admitted to expedite certain workups that we can't get in the community. We have nurse navigators, as I mentioned, that do intensive case management. They also do clinical interventions we have a small area where we can see patients if they're very sick and we need to turn them around instead of sending them to the emerge. We also use that as a place to recover them from a biopsy or a scope or whatever it is that we've gotten from the inpatient bricks and mortar hospital. And more recently, we've gotten a pharmacist to help with patient education and medication management. At home, we consider the patient and the community paramedics to be, and also the patient's caregivers to be the home team. And so the community paramedics basically do all of the labs and assessments and the IVs, but we've also empowered them to do a lot of the assessment of what patients need in their home, and to do a little bit on the social determinants of health and any barriers to care. And then we share an electronic health record so that the physician and the community paramedic can work together, and the paramedic follows the instructions of the physician, but paramedics and the nurses are also empowered to be an active participant in the care planning. The other thing that we realized about 8 months into our program was that some patients have different needs and different trajectories, and we modified our program. We created an acute arm and a subacute arm. And the reason that we did that is because we also took younger patients that just had medical conditions that we could manage on our hospital at home. But for the more vulnerable or frail that needed more case management or needed a little bit more time, we put them on a subacute arm where maybe we don't see them every day like you would in a hospital at home, but we were able to tie up some of those loose ends and prevent them from having readmissions. And also to use that time to come up with an action plan, test it out, and make sure that patients understood their care plans. And so depending on what the patients needed, we kind of adjusted the program. to be able to deal with both the people who can just kind of go straight through the program and get discharged, and the patients who need a little bit more time. One of the things that we did from the very beginning is getting ongoing patient and caregiver feedback and provider feedback. So this is from the first 4 years of the program. And you can see the patients had overall, the patients had a really good experience. 100% of them said that they felt treated with dignity and respect. 94% of them felt included in their care as much as they desired, and 80% of them felt prepared to manage their conditions after they were discharged. And this is part of, there was a lot of learning in our team that when you have a frail elder, sometimes you have to let them sort of live at risk. And mitigate risk for them. Like what we consider to be risk in a bricks and mortar hospital may not be what they consider risk at home, right? And if you start thinking about hospital at home as an intervention that reduces mortality, then maybe what we think is living at risk, maybe for them is not. And so there's been a lot of that readjustment in our team to try to respect that. This is ratings of helpfulness and impact, particularly because we had vulnerable elders. We really wanted to know how they felt sort of about the hospital at home program in terms of helping them regain their function and independence. And you can see that the majority did. The dark bars are before the pandemic and the light bars are after the pandemic, but you can see that most of them kind of tended to go towards the help me definitely. Can you go back? So most of the patients tended to talk about it being helpful and helping them to regain function. Same thing with the providers. Interestingly, it's actually 99% now with an N of 66 that thought that the complex care hub helped them regain function and independence. And one of the things that was highlighted by a lot of the providers that are internists who usually work in bricks and mortar is how much they learned about their patients through the hospital at home and how that made them understand how the care plans that they usually create when they discharge someone from internal medicine often miss some of the things that are really important for the patient to be able to succeed in the community. So what did we learn? We learned that we use the 5 M's in Canada, but incorporating the 5 M's really helps to get to what matters most for patients. And we tried to embed that in the program. We embedded it in the culture of care, in how we empowered the frontline staff, also in using rapid cycle changes as we were building the program. And this, as you see, led to the patients feeling that they were respected and that they were receiving the kind of care that they were looking for. But it does, for this particular population, the geriatric population, require a lot of intensive case management and a lot of like following up of loose ends. And that's it. This is just to acknowledge the team that worked with me.
Great. Thank you so much, Michelle. And I'll ask all the panelists to turn on their cameras. We do have a few minutes for questions. I just want to, there was a great question from one of the attendees about deprescribing. So Dr. Nassif, but anyone is free to chime in as well. And I'll just change the question slightly. Do you think there are any particular advantages in the context of deprescribing when you're doing it in hospital at home, say, compared to doing it in the traditional inpatient setting? Or have you guys learned anything about the deprescribing thing, which is really hard to do?
Yeah, and I'll say the one thing is, we need to publish it, but we started keeping track of what, they do a med rec in the hospital. They even have pharmacy techs doing these med recs in the hospital. And we still find out it's about 60 to 70% accurate. So I think that the first step of deprescribing is just knowing what they're actually taking at home and that they have multiple physicians and multiple healthcare systems prescribing things. But I don't know what exactly Jill does, because a lot of these people are, very attached to their temazepam and a lot of their sleep aids. But she has been very remarkable at getting rid of these medicines. And I think also it's the hospital in your home. We've tracked these things. Our practitioners and Jill are spending, an hour with these patients. We're in a brick and mortar hospital. You're spending 15, 20 minutes. And it's also, I think, much more reproducible about who's seeing the patients. I think there's another level of trust, and people are more comfortable and their family members are around. So I think it's multifactorial, but
I would agree with that. You can't deprescribe until you know someone is on something. And I've always thought of med rec in the hospital as a bit of a bit of science fiction. Shivani, next one's for you. You've thought deeply about the 4 M's, the 5 M's, the different settings, traditional hospital, hospital at home. Just wondering if you've given any thought to, the notion of how or if or how assessing the M's needs to be adjusted for the home setting versus the hospital setting.
Yeah, that's a great question. I do think so. I think, just as the common theme that I've heard from our other panelists is that power of being in the home and being on the patient's kind of home base where they feel comfortable. And so things like deprescribing, I think, are a little bit easier in some ways because you can have, I think, a fair conversation that doesn't necessarily feel as rushed. The one that I've been thinking a lot about, though, is that Mentation M. So first, when I initially tried to start thinking about this for our hospital and home program in Boston, I was thinking, okay, well, is delirium appropriate? But we are in the home, is doing those other two, the depression and the cognitive screening, just as important or actually more important? And, I know there's some work out there that has been published on delirium rates in hospital and home. We take the best pieces of the hospital in hospital at home. And so kind of, I think by nature of the care model, we're already doing many of the act-on tools. So I almost feel like we belong. So nursing home is interesting because on that worksheet, they have you do all 3. And I wonder if as more work is generated, I think this is going to be a good area of learning more about what our colleagues are doing in the variety of programs that are out there now on which ones are important. And I think from our work, though, that I've seen and the complex older adult population we have in the VA, the depression and the cognitive screen is really important because I feel like it doesn't always get diagnosed. And you wonder why Mr. Smith is coming back to the hospital multiple times. And we uncover things, I feel like, in hospital and home. So that's what my initial thoughts.
Yeah, when we did our work on hospital at home, a study in Medicare Advantage plans, or a few around the country, we looked at incident delirium, and part of the reason we did that is we thought hospital at home in many ways simply replicated the hospital elder life program kinds of approaches to delirium and found a substantial reduction. A question for our friends from Kent Hospital. Just wondering if you had any thoughts on how assessing physical function and mobility in the home helps with the transition to post-acute care. I know when I attend in the hospital, it feels like PTs and OTs who are doing God's work on earth, but they're seeing people in the hospital, not in their environment. And sometimes it feels they're making recommendations, say, for someone needs 24/7 assistance who never needed that before. And does being in the home and doing it there help? Do you think that helps you with those sorts of assessments and do better post-acute planning?
I think so. I mean, there is the same group that is seeing the patients in the home are going to be the same people seeing them post-discharge. So that helps very much, just that there's a continuity. The same team is going to be taking care of them. Whereas the group that's seeing them in the hospital is completely separate from the group that's seeing them post-discharge. So that right there has been helpful for us. I don't know, Aaron, if you had any other comments on that.
I think meeting with patients in their home, there's so much context to gain from seeing them function in their own environment and how they navigate their own homes and their way of living and their support system. And so being able to hone in on that assessment and really identifying specifically what their needs might be post-discharge, you might identify and see very different things than just hearing a description of it from in the hospital. So really getting to appreciate it with your own eyes, I think is really valuable and allows us to kind of target very specifically what those needs are from our own in-person assessment and hand that off to post-acute or post-discharge so that they're kind of getting the most relevant, accurate information to begin their piece of the care plan.
That's really helpful. Unfortunately, we have to start to close down the webinar. I just want to thank all of our speakers. Brilliant, brilliant jobs. So as we mentioned before, the Hospital at Home Users Group Caregiver Experience Study, if you have caregivers who might want to participate in that, we would love to have them. We'll leave that QR code up for just a second or three. As John mentioned, the Hospital at Home Annual Users Group meeting, October 17th. Be on the lookout for announcements and abstract submissions coming soon. All of our webinars on the Hospital at Home Users Group site, as John said, feel free to binge. And for more information about the users group, feel free to sign up. Everything is open source, everything is free, and we'd love to have you sign up. And John, do you have anything else?
No, thank you. I just again want to add my thanks, and again on behalf of the users group, thanks to our speakers today and to the John A. Hartford Foundation and the American Academy of Home Care Medicine for all their support in this work and for this webinar.